We're going to get started. Welcome, everybody. Good evening. Welcome to day 2 of the Health Policy Camp. This workshop is entitled Navigating Education and Healthcare Systems, Protecting Access, Attendance, and Student Success. My name is Chiyomo Rue, and I'll be serving as your moderator. I'm also the Health Justice Project Director here at Advocates for Justice and Education. But before we begin, I want to acknowledge our Spanish interpreters, Gabby and Javier from Latin Matters. Thank you so much for making this event more accessible to our beloved Latina community. For providing access and support. We are grateful for your partnership and the important role that you play in making this space more welcoming. Tonight's conversation is designed to help families better understand how our healthcare and education systems intersect and how we can work better together to ensure that children receive the services and supports they need to thrive. Before we begin, I'll review a few of our community agreements, and you can find them on the slide deck. You can, and please, after I read them, I definitely want your consent. So please give a thumbs up, if you agree, and I hope everyone consents. So we hope that this meeting, the grounding rules are to listen to understand, to honor lived experience as expertise, to speak from your own experience, to be mindful of time so that everyone has an opportunity to participate, to assume positive intent while remaining open to learning, to keep our conversations solutions oriented, and respect privacy and confidentiality, even if this is going to be uploaded onto YouTube. So please limit your private information as you with that in mind. Thank you all. I see the thumbs up. Much appreciated, much appreciated. So just to review to give you a sense of what you're going to get tonight. Very excited. We'll begin with the welcome and introductions, followed by 2 workshop sessions. The first will focus on healthcare systems, care coordination, and the second will explore navigating the education system. We'll bring them together, doing a whole group discussion on bridging healthcare and education systems to better support children and families. This will be an opportunity for participants to share their experiences, ask questions, offer ideas and recommendations as we learn from one another. We'll conclude with closing reflections, key resources, and next steps. And before we begin, I want to um, acknowledge any of our partners that are part of CHAP, our Community Health Advisory Panel, or any other AJE partners. If any members of City Council is being invited also are here, we welcome you. Please drop a note in the chat. Um, and I also want to make a few announcements, which is that we are currently collecting stories of family stories for our My Child Find storytelling campaign. This is a creative project to better understand families' experiences navigating early identification and special education. We encourage you to consider sharing your journey. And you can do that through multiple modalities. You can fill out the form, which is what this is going to prompt you to. You can opt to record a video if that's more accessible. And if you want to make an appointment with somebody to do an interview versus writing it yourself, you're free to do that. You can email us at advocacy@aje-dc.org. Amel, I hope you could drop that email in the chat. And um, and so I'm going to move on. I'm going to give you guys a chance to download this if you want. We will be sending this out. It is in your live binder as well. Links to it are in your live binder. So I'm going to go to that right now. I just want to let you know that we do have a live binder, which is it includes many resources referenced today. Actually, the presentation slides from today are uploaded in that live binder. One of the tabs towards the bottom says presentations. You can see the presentation slides for July 16th, which is today. And there are other useful information, and we hope that you download, use, share, and circulate the health information, please. And now we are going to launch our first poll. So I'm going to pass it to Danny to do that.
Thank you, Chioma. Okay, so before we hear from our speakers, we want to hear from your experiences. I'm going to launch the poll. Okay, which systems have been hardest for you to navigate? You can select up to 3 responses: IEP process, school attendance policies, Medicaid or insurance, care coordination, accessing specialists, school accommodations, communication with schools, or communication with healthcare providers. Okay, we have 6 responses. Let's try to get to 11. Okay, great. I'll share the results in just a moment. I'm giving people just a few more seconds to finalize their vote. Okay, great. So you'll see some of the top votes were IEP process, Medicaid and insurance, care coordination, accessing specialists, school accommodations, and communications with schools had a little bit more than communication with healthcare providers. So thank you all. I'll pass it back to Chioma.
Okay, thank you. So, our first workshop, which is healthcare systems and care coordination, I'm going to introduce our speaker. Our first speaker is Colleen Sonosky, who is so dear to me. I literally consider her a very unsung hero, and she deserves all the flowers for what she does for families navigating the CASP care system, which is for children with special health care needs. Her official title is the Associate Director of the Division of Children's Health Services within the Healthcare Delivery Management Administration of the District of Columbia's Department of Healthcare Finance, DHCF. Pass it to you, Colleen.
I think Danny is going to bring up my slides, right? So good evening, everyone. And I wanted to thank Chioma and Danny for inviting me to do this. Kind of the world of health and the world of education are the two biggest sectors that impact children's outcomes. So how they work together is really important. So as Chioma said, I'm the Associate Director of the Division of Children's Health Services at DC's Medicaid agency, which is Department of Healthcare Finance. And my main role is to oversee basically the pediatric component of the Medicaid program, which is known, I hope many of you is known as EPSDT. So next slide. So we always like to show kind of the importance of health insurance and the importance of Medicaid. For many, many years, DC has been one of the states that has had a very low uninsured rate, and that is something that we are very proud of and continue to want to try to make sure that that continues. One of the main reasons could be because of how small we are. So about 96% of all children who are eligible are actually enrolled. And in bigger states, it doesn't really quite happen that way. So it's good that we can get the children who are eligible and actually get them enrolled in the program. So that is kind of, the first step in all of this, because it's once you have health insurance, how are you using health insurance is also really important. So next slide. Oops, sorry. And this is, one slide that I have used for many years on trying to describe the pediatric benefit of the Medicaid program known as EPSDT, which I can kind of roll that acronym off my tongue. A lot of people cannot. But every word is important in that acronym. And I know that people hate acronyms in this town, but having an understanding of what the acronym is, I think, is also important for people to know the importance of the benefit. So the words early and periodic, screening, diagnostic, and treatment are all words that actually are adjectives for what the benefit is supposed to be. You're supposed to make sure your child gets seen early, and periodic is when needed. So I have a lot of conversations with providers and others around that issue around a child can only, especially when they're 3 and older, can only be seen once a year, and that's the only time it can count. In Medicaid, that is not the case. The child can be seen whenever it is needed. And so people should have an understanding of that. So one of the main things that we at DHCF need to do are make sure people have access to this benefit. So later on in the slide, I do have the link to brochures that we send out, that if folks don't know about the brochures, I would really like this group to have an understanding of that we do send out brochures and where they can get them. So making sure that as the administrator of the Medicaid program, that we are making sure people know about the benefit is a key component to to our role. Also making sure that people know that in terms of what needs to be done in a well child visit. So there is, for each age bracket, there are things that need to be done for assessments on the physical, on the developmental, on the behavioral health side. It's something that we have developed with the DC chapter of the American Academy of Pediatrics, and it's called a periodicity schedule, but it's what a child should be getting in a well child visit. And in a well child visit, doctors who are serving Medicaid kids are also supposed to be making sure that they have education to the parents, that they are giving something called health education or anticipatory guidance. So making sure that a doctor is talking to patients about everything that they should know. And so those are things that happen in a sense on the preventive side. Then the importance is, if there are things that need to happen from that well child visit, are there diagnostic services that need to happen, diagnostic tests or other treatment? Those are all services that can and should be covered under the Medicaid program, especially if they are services that are defined in federal law. So it is not every service under the sun, right? But it is still an extremely broad set of services that's defined under federal law that children in Medicaid should be getting. So next slide. And I think most people on this call know this, so I will go through this quickly, but I do like to describe how children are served through DC Medicaid. We have either the fee-for-service program or our managed care program. About 10% and maybe even a little less of children are served in what's called straight Medicaid or our fee-for-service program. And the vast majority of them, over 90%, are in our managed care program, which currently is AmeriHealth Caritas DC, HSCSN, MedStar Family Choice, and WellPoint DC. And I don't know if folks on the call have seen either recent news stories or information that we have sent out at DHCF, that the WellPoint managed care plan will be kind of closing up shop in DC at the end of this month. And those children, right, or all of those beneficiaries right now will be enrolled with AmeriHealth, but will have the choice to go to MedStar Family Choice. We can also talk later about the importance of HSCSN, which is our special needs plan, and how children can get enrolled into HSCSN. Thank you. Yes. So the next slide is, these are all things that should be helpful to Medicaid beneficiaries: having transportation, having scheduling assistance, having language interpreters. These are all things that should be available. And if they're not, it would be good for either your managed care plan to know that, or for us at DHCF to know that. Next slide. And this is just a quick, overview of the work that the Division of Children's Health Services does, which is primarily working with our managed care plans because they serve so many kids. And working with families to ensure access to care. Next slide. And one of the ways we monitor utilization is our kids getting services, like the claims that we are paying for and how kids are being served. One of the ways we do that is through a form that is reported district-wide to the federal government that's called the CMS 416. We also have our managed care plans do their own 416s, so we can monitor the managed care plans. And I can just show you some of the data from the past few years on the next slide with the most current data that shows the percentage of kids receiving their WellChild visits. So can you click next slide? Sorry. This one, yes. So this kind of shows where we were in FY19, and that's kind of an important date because that's pre-pandemic, and utilization for health services went way down during the pandemic, and the district has had kind of a hard time getting, I would say, kind of back to normal. We are still not pre-pandemic levels, but we in FY25 have done much better, and kind of looking at the breakdowns of the years of the ages of kids kind of shows you where we do need some improvement. So, I've always been surprised, especially pre-COVID. We were usually above national average with the 0 to 5 population. And at this time, we are actually below average with that population. And and as you can also see, as kids get older, the utilization does go down. But we are actually, in terms of comparison to national numbers, doing well with the older groups, even though the numbers are much lower. So if people have questions about this, you can reach out to me after. So next slide. So then Chioma and I and Danny talked through giving some recent updates within Medicaid. especially around the settlement that we have in the longstanding Salazar lawsuit, some recent federal Medicaid eligibility changes that are coming that don't really have a direct impact on children, but good for stakeholders to know. And then I've tried to list some CMS resources. CMS is our federal partner on the Centers for Medicare and Medicaid Services, and kind of some national resources for Medicaid and education linkages. So the next slide. Next slide on, yes. So the Salazar lawsuit was one of a longstanding lawsuit on access to services for children in the Medicaid program that had been going on since, I think, before 2000. So well over 20 years. And we reached a settlement agreement with the plaintiffs' attorneys in October of this year. And it took actually a little while longer than we expected for the judge to give a preliminary approval of the settlement that then required us to send out information on our website, via certain newspapers, via text and email to beneficiaries. So if folks do not have that information, I can make sure you know where to go on our website for more information. One thing that is important to know is that there is a fairness hearing that is coming up that needs to be conducted so the judge can determine if the settlement agreement is fair, and then she can rule on the final approval of the settlement terms. And the final date would be 2 years from October 31st of 25, which would be in 2027. So the next slide. So I kind of went through, we can go to the next slide because I kind of told you about the notice already. These are things that we would be continuing to do kind of with or without Salazar, right? We are going to continue to send EPSDT and dental brochures to all of our beneficiaries. We are going to continue to monitor the outreach that is required in the managed care plan contracts to make sure that beneficiaries know of their due and overdue services. And those were things that will continue on a quarterly basis. One way that DC Medicaid communicates with providers is through transmittals. So we will continue to send transmittals on the importance of children's health throughout the year, and continue to make sure that the managed care plans submit data to us on their 416 so we can see how they're doing. We also have a pediatric provider training requirement under Salazar that will continue with work that we will do with providers so they know the importance of the EPSDT benefit. And then, per federal requirements, every state is supposed to have the well-child visit schedule and a pediatric dental periodicity schedule. So all of those things will continue and be available on DHCF's website. Next slide. So this is some kind of new things that will be happening that are a part of the settlement, and that I think some folks in this group may be interested in. One of the things that was done was a regulation on out-of-pocket reimbursement and the procedures that need to take place. And one major change that happened is it used to be that families had only 6 months to be able to submit their reimbursement requests. They now have a year. So we want to make sure that folks understand that and that we have all that information out there. And then part of the work we'll be doing at DHCF is to monitor the compliance of the timeliness of these reimbursement requests. We also have put together information, lots of information on the managed care plans on DHCF's website. So that is something that is new, that had not been there before, and is kind of all in one place. It does take a little while to scroll through everything, but there is a lot of information there for people who are interested. Also, the development of, we've always done at DHCF, managed care report cards, but we took from things that are already reported for quality purposes, things that are specific to child health, and created a child health specific report card. So that is also something that is now on our website and will be done every year, and will be sent out by the managed care plans in their enrollment packets. Certain revisions or kind of more information in the footnotes were included in the most recent periodicity schedule. And then we're looking at making sure that there is a point of care billing code for blood lead testing. Things that are also going to be happening throughout the rest of this year and into next year is, and I hope folks on this group are interested in this, is the creation of a child health focused subcommittee under the Medicaid Advisory Committee that will include managed care folks, will include beneficiaries, will include pediatric stakeholders like yourselves. So Chioma, trust me, I'm going to be kind of hoping that you can become a big cheerleader of this and get people to participate. So that would be great. This will be starting in October. We're also meeting with some EPSDT federal advisory experts that will maybe talking with some of you folks, definitely folks at AGE in the next few months around things that, we could continue to do to improve children's health outcomes in DC. Also developing a managed care performance dashboard that puts together lots of other information that is probably included in the Medicaid reports, but puts it in a more dashboard, kind of usability. And then some other things around value-based payments that have a pediatric focus, because a lot of times value-based payment only thinks about the adult side of the world. This kind of puts in that DHCF needs to focus on pediatric in their value-based payment methodologies, and looking at timeliness standards and network adequacy. So all of those things are happening. After the fairness hearing on the 13th, I will probably have more information about the grant funding that will be available. I don't quite have that right now, but it will be something that we'll be able to advise folks on after the fairness hearing. So next, thank you, Chioma. Next, so there's also been lots of recent changes in federal Medicaid law around eligibility changes. So the next slide is that it makes changes that will have some effect on district residents. Let me go actually to the next slide, and I think that I can describe it more as for this group, because I think I want folks to understand that no changes on the financial eligibility side for children 0 through 20 or pregnant individuals, or those who are in disabled or in long-term care. It does affect childless adults, some parent caregivers. And so having that information of who is impacted and who is not impacted, I think is always important for stakeholders like yourselves to know. And for for children, that if you're thinking that your child is about to lose Medicaid coverage because their parent caregiver may be losing Medicaid coverage, please make sure that you confirm that, because the child should not be. Okay. So just having that understanding, I think, is important. As I think Chioma is putting in the chat things about the Medicaid Advisory Committee and the Beneficiary Advisory Committee. Lots of this information happens at those meetings that I will have a slide on in the next few minutes. Next slide. Because so there are changes again to non-citizen eligibility changes. Again, for children under 21 and pregnant women who are lawfully here, they should not be impacted. So, like, having an understanding of who is impacted with all of these changes and who is not is extremely important. Next slide. Yeah, and then I think lots of you have probably heard about work requirements. And that is on both the SNAP side and the Medicaid side, that will require primarily childless adults. So those in the childless adult eligibility group who are not exempt, that they will be required to show some type of work hours, some type of community service, some type of education. And that is something that, there's information that's kind of flowing out of CMS, I would say weekly. And folks in our agency are working on the best way to implement this and getting the best information out there. So if there's any questions, you can let me know, and I can let you know who to talk to. Again, because work requirements and some of these eligibility changes don't have a direct impact on children. I don't have all of that information, but wanted to share that with you tonight. So next slide. I think the next slide is about who could be exempt. So there is lots of information here that you could reach out to me specifically, and I can either let you know the answers or let you know who to talk to at DHCF. And then, so a large part of what we are doing at DHCF is trying to do some community outreach, so people know on both the MAC side, the back side, and then we have meetings, I would say, every other week and monthly for beneficiaries to get this information. If there is any question that you have on these changes, you can send it to medicaid.renewal@dc.gov. You can be put on a listserv. You can get information that way. So know that there are ways that we want to provide as much information to beneficiaries as possible. Next slide. So we're actually in the process of taking on some MAC and back applications that I think Chioma can also talk to you about too. But if you have any questions about this, you can let me know. And if you have any interest, we want as many people as possible. So next slide. And these are ways to get involved. The next MAC meeting will be in August. This is the email, dhcf.mac&back@dc.gov. If you want to be added to the list and making sure that you have information. Again, I would love to, get anyone who would be interested in a child health subcommittee of the MAC. And if you'd like to be included in that, we will start a list, probably starting in September. So next slide. So these are sites that you can go to on our website on the Medicaid changes, if you ever need them. Next slide. All right. So I know that this whole event tonight is around kind of integrating education and Medicaid together. And so just for you to have kind of an understanding of the role of Medicaid and payments for services in schools is, primarily our main role in that is we pay the LEAs for services that are provided in schools for children who have IEPs. Okay. And there's a lot of work that has been going on over the last decade around states deciding whether they want to expand that or not expand that. It was maybe now about 10 years ago, DHCF worked with schools, with DBH, with DC Health, with OSSI on looking into would it make sense for us to do this. And after many months of kind of deliberation around this issue, we decided at that point, and again, this was in 2018, that it was not something we wanted to do at the time. In 2023 or 2024, under the former administration, they put out a new kind of Medicaid billing in schools guide that I would say said to states, maybe you should think about this or rethink about this. And so that is still something that we have not moved from status quo yet, but that does not mean that that can't happen sometime in the future. The national organizations that we've worked with in the past on this issue are Healthy Schools Campaign and Healthy Students Promising Futures, and they have a lot of the information about what other states are doing and what the major issues are. And then there's also other agencies who are involved with school health. Okay, so DC Health has a number of school health programs. They have the school-based health centers. They have the school nursing suites. They have a school-based oral health program. That is all local. That is all basically local funding. And so that thinking through how services are provided in schools are kind of is that broader question to think about, along with DBH, who has the school-based behavioral health program in many schools. Again, that is primarily locally funded. So, I think that this is a question that as we get into the other presentations, kind of then knowing where Medicaid does fit in or could fit in the future, where other agencies should fit in, I think, I wanted to set that up with this slide. And then I think my other slides are primarily around other resources that we have on our website, and the training and resource website that we have with dchealthcheck.net, and our brochures. And I think, Danny, is that it? Oh, and then CMS resources on children's health that I thought would be of interest to this group.
And I'll send these slides over so you guys can have the links as well.
And then this is my phone number and my staff, and we are always helpful, always willing to help on whatever you need. So Chioma and Danny, I hope that helps set up the health side.
Thank you, Colleen.
Thank you so much, Colleen. This is very informative, and as I put in the chat, I've been a member of the MAC since I think 2022. It's gone through some changes. We've gone through administration changes. It's a great body to learn, and I'm glad that they've stood up the back, which is more beneficiary centered. Definitely encourage all of our parent ambassadors or any of AJE connected parent leaders or CLC parent leaders to join. So please circulate the information. I'll also say that in the live binder, we have Colleen's presentation slide. So if you go under the tab, which is the second to the last on the bottom, this slide deck is there, and you're able to click on the links in the slide deck to get to them, I believe. And also on the live binder is under the other tab called right above it called CHAP advocacy briefs, are one pagers that we came up with earlier this year with our CHAP, our Community Health Advisory Panel, to give information about the school-based health centers, the school-based behavioral health program, and shout out to Children's Law Center as well. We're proud to be part of the Strengthening Families Coalition, which advocates specifically for the school-based behavioral health program. And then we also have a one-pager on the DC School Health Services program. And on that, please, if you have any questions or comments, we just take a few minutes so that you can do so through the chat. If you want to come off mute and share your thoughts, please raise your hands and we'll call you in order. So give a few
We have
moments.
time for 2 questions, if anyone has any questions.
Yep.
I have a question, but I will let other people ask their question first.
Go for it, Maria. Maybe
All right.
folks will be thinking of their question while you're saying yours.
I'll break the ice for everybody. So Colleen, one, I really appreciated your presentation. I think I've seen you do this talk like 3 times now over the last 10
Sorry.
years.
Right.
No, it's perfect. I learned something every single time, and I am really glad that you have validated my inability to say EPSDT with any degree of fluidity, because I mess it up every time. But I wanted to just make sure I heard you right. You were talking about how DC had opted out of LEA billing for Medicaid eligible services. And I wanted to make sure I heard that right, because parents are asked every single year to sign a consent saying it is okay. And then we had a whole kerfluffle last year with whether or not, schools can do it without parental consent. So I just wanted to make sure I understood where things are now. I know we've had some back and
Sure.
forth, and I know some LEAs have opted out.
So the opt-out that I was talking about, so currently, the way our state plan is set up, okay, and that's how things can get paid for by Medicaid, is that a child who has an IEP, who is receiving the services that are defined in our state plan, so there are about 10 or 11 of them, okay?
Right.
Medicaid pays the LEA for those services for those kids. What we decided not to do many moons ago was expand that so that it would be children who did not have an IEP, but were in Medicaid and were getting a Medicaid related service. So we decided to not do the expansion. We have always done the payment of services in the IEP. Does that help clarify?
That makes so much more sense.
Okay.
Thank
Sorry
you.
about that. Sure.
No.
Sorry.
I just had this moment where I'm like, have I been very
What
wrong
is,
in my understanding of things? Oh my gosh.
and
Thank you. It was the
yes,
expansion to non-IEP eligible
is
kids.
what we decided not to do. So
Okay.
our status quo is IEP only.
Okay.
Other states have gone a different way in I would say the last decade. We still have not, but that doesn't mean that we never will, right? So there's lots of issues in terms of there's this random moment time study that schools and Medicaid have to do that it like you bring up one thing and it peels an onion back in 5 or 6 different ways. So there are many issues to talk through with this. It is still something that could be talked through, okay, but it's just not status quo. The status quo right now is IEP only. Does that
Okay.
help?
That helps tremendously. And I
Okay.
think
Okay.
it's important to note that not every LEA opts to submit for reimbursement just because of the administrative burden. And that was something that I was really surprised to
Oh,
learn. I was like, so a lot of only big LEAs submit for it because some of the smaller LEAs are like, this is such an administrative burden for us, it's not worth it to
right.
do this. But I will be quiet now and hopefully somebody else has questions. But that was super, super helpful to me. Thank you.
Oh, that was very important. Thanks, Maria. I think I saw Brandon come off mute. Brandon, do you want to ask the second question?
No, I just got in from the I think it's the American Indian um conference they're having out in Arizona, but but no, I was just wondering um for Maria what books are your favorite from the bookshelf behind you? Um if 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 that's too random a question, sorry.
It's a
I will
very
put it in the
spicy question. I love
I
it.
will put it in the chat. I will contemplate that and put it in the chat in a minute.
I will ask Colleen, a couple of our parent ambassadors are recipients of Wells Point, and they had noted that they hadn't received any notification. And that the first time they heard about it is us telling them that we were going to have our parent cafe, which is this Saturday as part of the camp. We had to move it from the 25th to the 18th because they're not going to be open on the 25th. And the only time we could host it was on the 18th. So then the question I have is in terms of how notifications are going out to those current enrollees, have they gone out? Is there a reason why, if they have gone out, is there a reason why some
Somebody
families are not
hasn't.
receiving them? Yeah. Or is there
So,
another outreach strategy here? Yeah.
so I do not have the exact dates of when something has gone out. I thought something had gone out, so if folks want to reach out to me, I can put them in touch and we can find out why they have not received them. So that would be, I think that would be the best way to do it, but they are going out either by letter or a text. So I will get that in, I'll get that information for you, okay? But if they have not received anything by tomorrow, have them reach out to me and I'm going to get them in touch with somebody in HCDMA, okay?
Great, thank you. Will do. And I see Pepper, you have your hand up, and I know we've got to move on. But Pepper, if you could just make it real quick, and we'll take that time off of Maria's presentation, considering the first question.
Sorry.
Hello, everyone. Happy Thursday. So I just wanted to mention, as far as the letter, they are sending out letters saying that they have to a certain amount of time to switch, or they're automatically being switched to AmeriHealth. So they are receiving letters in the mail.
Yeah, that's what I thought.
Yeah, I have one parent that didn't receive it, so I don't know what that's about, and we'll redirect. But Danny, I'm going to punt it to you, please, if you can do the second poll, and I know we're behind on time. Go for it.
Thank you. Okay, so let's go ahead and launch the second poll. Give me all 1 second. Thank you, Colleen. Okay. Can you all see it?
No.
Okay, now it should. So the second poll question is, what are the biggest barriers of communication between your child's healthcare provider and school? Select up to two responses. And in just a little bit, we'll hear a little bit more about the school system from Danielle and Maria.
You know, you guys like have to answer this poll, so I have something to say during my presentation. There we go. Thank you. Or gonna leave me adrift. Paperwork. Not sure.
I think my screen is frozen. Y'all okay?
I think we're
Okay.
good.
Let me turn off my camera. Maybe it helps. Okay. So we have 6 answers. Let's try to get a few more. I'll give you all a couple minutes. I'll share the results in just a little bit. Right now, the top votes are difficulty reaching the right person and delays in getting records or paperwork completed. All right. So I'll go ahead and share the results, and definitely delays in getting records or paperwork completed has the most votes, and then you can see the other ones that came close. All right, so thank you. I'll pass it back to Chioma to just briefly introduce Danielle and Maria.
Yes, great. And I will note that we have a one-pager on records and getting your medical records in the live binder. So hopefully that helps with that a little bit. But transitioning to our next session here, we're bringing together two outstanding legal eagles, the wind beneath our wings here as parent leaders who work every day, diligently to protect the rights of families, DC families, navigating the DC education system, and to protect students' rights specifically. So, first, we're joined by my colleague, Maria Bloyer, who's the Director of Programs and Outreach here at AJE. And we're also pleased to welcome Danielle Robinette, who's a Senior Policy Attorney at Children's Law Center. We'll now transition into this second workshop. So, welcome, Maria and Danielle. The floor is yours.
All right. Okay, so Danielle and I are probably not going to be nearly as, oh, I don't know, information rich as Colleen was. But we are going to try really hard to make this practical and kind of bridge the gap between the theory of how, the screening and the information and the resources available in the medical space, how that actually shows up when you're trying to work for better outcomes for your child in the education context. Um, so that's what we're going to do. That's why it's a conversation about policies, practicalities, and potential pitfalls. Um, Danielle, I don't know if you want to tell people a little bit about your work. Most people here have seen my face more than maybe they want to. So I think it'd be kind of helpful if you're like, hey, I'm not just Danielle from CLC, I am also.
Absolutely happy to. Hello, y'all. For those who don't know me or haven't seen me ramble with Maria about something before, I'm Danielle Robinette. I'm a senior policy attorney with Children's Law Center, where I lead our education policy work. That is sort of a broad umbrella, but generally my work is focused on student attendance and discipline and special education, especially where those things intersect, and to the degree that they uniquely impact children in foster care, because Children's Law Center, we represent about half of the children in foster care in the district. So that's sort of where I'm coming at this from.
Okay. So I wanted to very quickly kind of give you a highlight of our agenda. And the reason I wanted to do that is because I think it's important to know how the education system has just a very different framework for how it defines what it's doing. Um, the healthcare system, I think we all have a pretty clear idea that the healthcare system is about healthy outcomes for kids, whatever that means. But I think sometimes we don't always know what the goal of the education system is. And that can really impact how those two systems intersect with each other. So we're going to talk a little bit about the goals and therefore the legal mandates in the education system. And then we're going to talk a little bit about kind of the way the education system achieves those goals. And that's really going to be a little conversation about IEPs, 504 plans, and nursing plans, how school-based providers intersect with all of these goals, but also, kind of what that means from a legal standpoint. Um, and then understanding the educational decision-making process. I think one thing that we don't always highlight enough here is the remarkable amount of power that parents have in this process to control the flow of information um, between schools and the medical folks that are serving their kiddo, and how that cuts both ways, right? Like any kind of power, it has pros and cons. And then we're going to talk a little bit about parent rights and students' rights. Again, a lot of that's going to be around that consent and information flowing. But I want to kind of lay the groundwork. That's what we're sort of looking at. Is there anything on this list where someone is like, hey, you've completely forgotten something, or I don't understand why we're talking about it? All right. All right. Um, I think this is a Danielle slide because she
Yeah.
loves this issue.
Thank you, Maria. So wanted to sort of start with why our kids go to school in the first place. I think this is one of my favorite sort of philosophical questions is like, what are schools supposed to do? What is actually the reason we go? So to save you from my full soapbox, we have sort of a focus here on the legal reasons why kids go to school, and it's because they're required to. So all children, you can read it here on the slide, children residing in the District of Columbia required to attend school from the age of 5 until they are 18. Um, this is called the compulsory school attendance requirement. It just means that kids in that age group must go to school. That schooling to meet the law can look various ways. It can be a kind of traditional public school. We have charters in the district. It can be virtual programs that are kind of authorized by the jurisdiction. Those are private schools and parochial schools, and even homeschooling, which I know Maria could speak better about than I can. But this is ultimately why kids go to school, is because the law says you have to send them.
And I think that last sentence is the key sentence. The law says you have to send them. In DC, there isn't a right to attend school that's vested in children. Instead, we place a burden on families to send them. And that's the compulsory school attendance. Danielle always puts this really well. And she's like, that's why kids can't sue schools for doing a lousy job, but districts can sue parents for not sending them because of the compulsory education part. Okay. And then I always like to kind of talk about like, what do the schools think they're doing, right? Um, and you'll notice that none of this is about healthiness, but these are the district's three largest LEAs, local educational agencies. So between these three mission statements, we've covered, I think, actually almost 3/4 of the kids in the District of Columbia. It's the two largest charter LEAs and DCPS, which has about half the kids. Um, and you'll notice, we've got some pretty eventful, standardish language here, right? Kids go to school to get a rigorous and joyful learning. That's pretty up there. Academically excellent, right? Um, and then friendship is talking about world class, right? So these are, really robust, you know, I think the friendship one's probably the most robust, right? Ethical, literate, well-rounded, self-sufficient citizens who contribute actively to their community. But that's what the education system is saying that they're trying to do. Okay. Um, but again, there is no affirmative right. There's just an obligation of the parent to send the child somewhere. Um, but when we start thinking about what the law requires that kids with disabilities get, we see some very different language, right? So we've got rigorous and joyful, um, academically excellent, world class, and then we come over here to IDEA, which is where we see the expression of the goals for the education of students with disabilities. And we have a very different term. We have appropriate. You know, we have a free, appropriate public education that emphasizes special education and related services to meet the unique needs and prepare them, being the students, for further education, employment, and independent living. And you'll see over the next couple of slides, I've got some highlights because unique needs and independent living is where we really start to see some of the more express intersection of health and education policy and law, right? Because the child, especially a child with a disability, can have unique needs. And then addressing those unique needs, making sure they have the skills to manage those needs, particularly if they're health related and can impact their ability to have independent living later. And independent living is an express stated goal of IDEA. I also always like to flag for folks that post 2017, after the Andrew F. decision, special education gets its own big word too, right? You know, it's not rigorous, it's not world class, but it is appropriately ambitious. That's something that John Roberts said in the decision in Andrew F. And I just think it is so important because it is starting to take, you know, the free, appropriate public education and make it a little bit more comparable to this world class, rigorous, joyful, well rounded, world class thing, right? At least now we have it's appropriately ambitious in light of the child's circumstances, you know, which I have a whole spiel about how that also means that they're, you know, the child's entitled to failure at that point, which is good. You know, failure is what teaches us. Okay, but that's what the education system is trying to do in that context. And then there's some other things that we see like laid out in a lot more detail in IDEA that are relevant to the health system. And that's to make sure that, you know, there is a plan for serving all students with disabilities and serving and making sure that there's a coordinated system of care. And you'll see these are all the other goals of IDEA as laid out in the statute. And you'll see a lot of this stuff kind of makes you start to think a little bit about what Colleen was talking about with some of the early periodic screening and diagnostic whatever that thing, you know, the EPSDT. You know, what are you entitled to? Because that information is supposed to be part of that comprehensive, coordinated, multidisciplinary, interagency system of early intervention services for toddlers and infants. That is so much. That is so huge. But I want to let you know there is a vision, right? There is a vision where that system is talking to the education system. It's just kind of buried in the statutory language of IDEA. And it is also a macro articulation of this mission. It is not micro. It's not Timmy gets a
You,
referral.
right. You don't read the sentence and say, I know exactly what my school is supposed to do.
Right.
You read that it's supposed to be comprehensive and coordinated and involve lots of people. But I think where the rubber meets the road is that that sentence doesn't actually tell you what does that look like, who needs to be there, who should cooperate with whom to do what, so that students have this experience that we're telling them they should have a right to.
Right. And it also doesn't tell you how, and it doesn't tell you what medical systems should do. Right? This does not tell Colleen how to talk to a school district about the results that she has from the periodic screenings. It doesn't do that. So I think one of the things that's so important about both the health policy camp and kind of work that the health justice team is trying to do generally is making sure that people who are actually impacted by these kind of statutory big ideas participate in the rubber meets the road work, which is the MAC and the BAC, all those advisory committees. There's a million of them. Pick one. Um, but that this is, you know, this is what's going to be making that real. And then I also, because I feel like this is an underappreciated law, I always like to talk about how Section 504 impacts this conversation as well. So we have, and I do this all the time for those of you who've been in sessions with me before, we have our highfalutin education goals for the whole system, you know, rigorous, world class, all that, academically excellent. And then we have appropriately ambitious. Okay, that's our kind of goal for education in under IDEA. That's what IDEA is trying to make sure happens. And then Section 504 is just trying to make sure students aren't excluded and have access to what everybody else has access to. And I think that that's important because we're going to talk more a little bit later about, some of the rights and protections and barriers that families experience. But I think it's important to note that the education system's goals, as viewed through the lens of Section 504, is just to make sure that students who have a disability, um, and then they've got a pretty broad definition of disability under 504 as compared to IDEA, which has a much narrower disability definition, aren't excluded from or unable to participate in. Um, the rigorous world-class education, right? So if everybody gets this rigorous world-class, ambitious, education up here, that's a program that is supported by the federal government. That's DCPS's mission. Section 504 says you can't exclude students with disabilities from that program just by virtue of the fact that they have a disability. So hopefully that makes sense. And then how do they do this? Do you want to talk a little bit about this, Danielle, and then I'll come back and talk more?
Happy to. So bringing it down from the highfalutin level, the entire point, I think, of all of these plans is to make sure everyone knows exactly what is supposed to happen, right? So if your student has an IEP, that tells the school what they need to do in order to meet this child's needs. 504s are do a similar thing. They're more often for maybe what to do in very specific circumstances instead of maybe every day. But then sometimes those things come into conflict with the attendance policies that we talked about before, that you are required to make sure your student goes to school. Well, parents or caregivers, that whoever's responsible is required to make sure that student goes to school. And so what happens when a student's health concerns impede their ability to go to school or mean that they miss more days than their peers, or unpredictable things are going to happen, right? And that's where I think the goal for this conversation is to make sure that we understand first sort of instances and when that is most likely to happen, and what rights parents and caregivers have, what rights the students have, and what sort of tools you have to make sure that students are getting the most of both their medical care and their education. So that in the district, we have a couple of programs that kind of specifically address or I guess recognize that there are going to be times where health and school interfere with each other. And so we have programs like the Home and Hospital Instruction Program. This is another soapbox of mine, but it is for students who have a health condition that requires them to miss more than 10 or more days of school. That can be either consecutively, meaning all right in a row, or that could be cumulatively. Perhaps there's a chronic illness, something like Crohn's or sickle cell, where you may not miss 10 days straight, but you might miss 2 or 3 days regularly, and you're going to hit 10. So that program is supposed to bring the education to the student in a way that is accessible to them. So if the student is in a hospital-based setting, they can send a tutor there. They can send a tutor to the student's home. We also have what's called the school-based behavioral health program that Chioma mentioned earlier. This is a program in which the DC's Department of Behavioral Health puts clinicians into schools. So these clinicians are not employed by the school, but that is their kind of where their office is every day, right? The clinician shows up and is able to provide those services where the students already are, rather than that student having to perhaps leave school to go to a behavioral health care appointment, because doctors and schools are open at the same time, and that's really inconvenient. So, and then the last is the school nursing program. This one's probably the most kind of commonly understood when you're thinking about healthcare in school. This is the school nurse who um, perhaps your child needs to take medication during the school day and needs an adult to administer that and make sure it's done correctly. Things like EpiPens, inhalers and nebulizers. And then also like kids fall down and scrape their knee and need sort of that sort of health immediate, but not, requiring an outside facility. So there are lots of times, I guess, is both predictable and unpredictable when health concerns are going to conflict with this compulsory education requirement.
Right. And then I think we have, and I kind of feel bad for Danielle because I think I might have said I would do this slide and then I accidentally threw it at her just now. So I
No
apologize.
worries.
But I think one thing that we need to remember too is that for a long time, I think sometimes in these conversations that we had, we thought of attendance as separate from a disability issue, right? And the law is very clear. Attendance, school avoidance, being at school, attending school can be considered to be related to a disability just like anything else, right? Just like a behavior. It is just a behavior. It is just potentially a manifestation of the disability. And we've had, good guidance from the federal government for over 20 years on that point. But for some reason, it got a little stuck in people's head that attendance was different, right? And it's not. Okay. It's really not, especially if it is connected to a health concern, including a mental health concern. We can plan around that. We can incorporate it into the IEP. We can incorporate it into a 504 plan. We can operationalize it into a home and hospital plan. And I think one thing that I'm thankful for is the federal government recently issued some very clear guidance, and DCPS agreed to it, that they will not treat attendances differently, and they will make, plans as appropriate for students with disabilities whose ability to attend school is somehow impacted by their disability, which I think is a significant win because I think a lot of us have had, and you can just kind of give me a little emoji thing if you've experienced this. Um, you know, if you've experienced a conversation with the school and they go, well, they're not coming to school enough for me to be able to tell whether or not they have a disability, or I can't evaluate this student because they're not in school enough, or yeah, without more regular attendance, I can't, we can't make any decisions about 504 or IEP because we just, we don't know yet. And that's the law says that's not what we're supposed to be doing. We're supposed to be looking at that as part of what's going on. And
Right.
I
What
love,
is that a sign of? What is that telling you rather than being a reason you can't learn anything? What can you learn from that behavior in and of itself about kind of what the child's needs are?
right. And I think that problem, that solution orientation to looking at student behavior is really, really important. And then I love what Adrian added, which is, basically bullying and PTSD can cause absenteeism. Yes, schools can be, and this is a hard thing for many schools to hear. Schools, should be a place of safety and joy and liberation, and they are often not, right? And that can cause this, schools can unfortunately be disability creating environments. They can be places where students, have negative experiences that result in things like, PTSD, which can, unfortunately rise to the level of being something that requires a 504 or an IEP plan to address. Um, and then I wanted to ask you, Danielle, a little bit about the school nursing program while we have everybody
Mhm.
here. Um, we, everyone loves school nurses, you know, but are they always nurses?
They're actually usually not nurses. So often in the district anyway, they are, is it a CNA? Is that the right acronym?
I
Um,
think so.
so I think DCPS calls them health techs. So it is a person who is probably allowed to administer medication in a very narrow sense, that they have been trained to administer it, specifically the medications required by the students that they are serving. But you wouldn't find them in an emergency room, at least not, running anything by themselves. So they are trained. I don't want to imply that they don't have medical training, but they're not going to be or usually are not going to be a registered nurse or APRN or some of those acronyms you might be more familiar with from your pediatrician's office.
Right. And thank you, Jim, a school health technician. I think one
Thank
reason
you.
why I like to flag that is that we've got really good case law about how it doesn't actually, I mean, I want to nurse a lot of the times also, but there are many, quasi-medical services that can be provided
Mhm.
by a trained non-nurse, right?
I mean, and
Um,
imagine if you have a student yourself that requires sort of additional medical care at home, right? You learn those things yourself to care for your child, and that no one gives you a nursing degree, but you learn a significant amount of how to provide health care to your child when you parent a medically complex child.
Right. And I love that. I love that point about the fact that you learn, this stuff, right?
Mhm.
And schools can be, school staff can be required to take additional training. And there's a Supreme Court case about this exact issue about catheterization, about how school staff can be trained to deliver
Mhm.
catheterization to allow a student to attend school. And then I see Jocelyn's question, and I just kind of want to flag that I can't tell you for sure whether or not one particular student would qualify under a home and hospital instruction, but I can tell you that the general rule is 10 or more days because of a condition, and that can be like intermittent care, right? But that's a conversation you have with the doctor. Can the doctor support a home and hospital application? And we'll talk a little bit more about that process in a second. Um, but in true lawyer fashion, as I know you've heard me say before, at least, it depends. It depends. But you're thinking about it the right way, which I think is the point of this conversation today. Um, and we've kind of already said this. This is two systems that really overlap in terms of who they're serving, but not necessarily overlap in how they're talking to each other. And in the district, we put a tremendous amount of the burden on facilitating that communication on the parent. And as a person who's now done 36 years in aggregate of filling out school health forms, I feel that burden acutely, right? But I want to let Danielle talk a little bit about the Universal Health Certificate and kind of how that's an exemplar of this communication disconnect between schools and the medical system and how we ask parents to do that work for us.
Absolutely. So I think an important kind of part that underlies both of these kind of both sides of this coin is that the parent or caregiver for an individual student generally holds the rights to their kind of that student's private information. So there is a federal law called FERPA that protects your educational rights. And then there are all sorts of other laws in the medical space that protect privacy of medical records. So, because schools are not just supposed to share your information with anybody who asks, and doctors are not supposed to share information with anybody who asks, the person with or the person with the power to authorize that sort of communication is often the parent or guardian. So, because there are overlaps between health and education, there are often times when the school wants to speak directly with the doctor or the doctor wants to talk to the school, and they aren't usually, I shouldn't say always, but they aren't usually allowed to do that without the parent or caregiver's explicit consent. Unfortunately, what that creates is a burden on the parent to be the go-between the school and the doctor, right? So the school's like, so if we use Jocelyn's example, if the school says, well, we want to consider whether or not these menstrual cramps could qualify for this program, but we need to talk to the child's doctor in order to understand what's going on. And so then the parent has to give permission for the school to talk to the doctor and for the doctor to answer any questions back to the school. And that really kind of makes the parent the go-between. And that's a lot of burden. I don't know if anyone's ever sat on hold with a pediatrician's office, but it takes forever. I think, Daniela, I don't know if you still have those Zoom results from earlier, but I think one of them was delays in getting records transitioned.
Sure.
It takes a long time and everybody's busy. And in the meantime, kids are just sort of sitting there, and the parent is the one that has to keep calling and reminding, like, hey, the school sent you this form. Can you fill it out? Or then you have to call the doctor and be like, hey, I need you to fill out this such and such. And getting an appointment is forever. And I recently discovered, maybe this makes me naive or just shows that I don't have kids of my own, that there are doctor's offices that charge you to fill out these forms, even though they are required for school. So, one of the specific examples, this is what Maria wanted me to talk about, and now I've rambled for quite a while, is the Universal Health Certificate. So, if you have a student in the DC public or public charter school systems, you have filled out this form or signed to authorize your pediatrician to share this information regarding the Universal Health Certificate. I think it's given out every year. Is that okay? I couldn't remember if it was a just
Yeah.
change of enrollment or every year. I thought it was every year. And this is stuff like, has your child received the vaccines recommended for their age group? If not, do you have a X, Y, or Z exemption? Have they had this screening? What else is all on that form? Do they have any medical needs that the school should know about? Like they need to take medicine at noon every day. And the only way the school can know that is because the parent authorizes them to know it, but that means the parent has the burden of filling out this form every year, as Maria will say. How many? You got 36? 3 times 12 years?
Yes. That doesn't include
There's
pre-K.
probably some kindergarten. Yeah, there's some kindergarten. There are extra sports physicals. It happens. You filled it out a lot, is the point. And so there are legislative proposals to try to address this administrative burden side of this. They are brand new. I can't speak to them extensively, but they are recognizing that it's hard for parents to do this back and forth, to be that go-between, and it takes a lot of time. And so there are proposals to build, I don't know, like a database of sorts that your pediatrician would upload the information that the schools want from the Universal Health Certificate, and then the schools can just see, and it all like the parent does not have to be involved. The doctor uploads, the school can then receive it. Parent doesn't have to like play messenger. And that same proposal includes a ban on charging for the filling out of that fee, which is how I learned that there are doctors charging to fill out that form. And so the Universal Health Certificate, I think, is probably a really kind of, hopefully you all like have had to do it and you've filled it out, but I think it is really the form that is every parent of a student in the district has grappled with these questions of, where does my student's education and medical needs kind of interact?
Yeah. And I think one thing about the proposal that you were just talking about is it removes or it kind of hides the parent's consent to this information sharing, which is why it's sort of interesting, right? Because the thing that has made this an administrative nightmare is the fact that the parent is both the, by definition of the fact that we have the power to consent to the information sharing and we're the only ones who do, we are also by definition a bottleneck, right? We are where information often stops and slows down because, all of the burden has been put on us. But the flip side of all the burden being put on the parent is a loss of the control of how the information is shared. I do want to share a pro mom hint that former AJE, my predecessor here at AJE in this position, Molly Whalen, shared with me because she was and is, I think, just a brilliant person. She photocopied that thing before she signed it every year. And then the next year, all she had to do was update it, photocopy it again, and then sign the new one. So she's like, I went from filling that thing out, taking an hour every year, 2 hours every year to 10 minutes. So I was like, okay, that is the hint. So see, practicalities. We are a practical bunch here. All right. So I think we've talked a little bit about the kind of the pain points, right, where this intersects. And one of the things that Chioma asked us to talk about was kind of the pain points and then the programs and the policies and the rights that are on the opposite side of those pain points. Um, when these systems don't intersect or do or don't intersect so well. So so we've talked a little bit about the home and hospital program. But there's also places where we can make changes to a student's IEP to address health needs. And I think this is something sometimes that we forget about. Um, and we can also make changes to a student's 504 plan, to address some of the things that might not be related to their core, the core reason they have the 504, the health plan. And I think that's the other thing to remember too, is that students shockingly can have more than one thing going on in their life, just like the rest of us, right? You can be a student with a learning disability who is also anxious, who also has asthma, who also has, some trauma as a result of, oh, I don't know, being a student with a disability at all, right? This is a lot. So you
Mhm.
can have compounding multiple things going on, and we can include those things in the IEP or the 504 plan if that is something that would help that student access what they are otherwise entitled to. Um, and then I also want to talk a little bit about student mental health kind of separately from this, because I feel like sometimes we think of student mental health as qualitatively different, or behavioral health as qualitatively different than other parts of health. And that is just not true. Mental health is
Mhm.
healthcare like any other kind of healthcare, which means that um, mental health needs that trigger absences are just as valid as illnesses, as other like physical manifestations of like a
Mhm.
fever. It is just as valid. And the parent has the same ability to excuse for mental health. Now there's a limit on how many days a parent can excuse without documentation. That's in the live binder. But I want people to know that you can do that. And there is nothing wrong with that. But it also means if you find yourself, and this is something that I do think where we can talk a little bit about the how these systems talk to each other. Um, your doctor should probably know if your kiddo is missing school,
Mhm.
um, because that is not information they get. With some exceptions, there's a program that does some information sharing. Danielle can tell you about that, but it's kind of a off on the side pilot
The
attendance
exception,
program.
not the rule.
Yeah, generally the doctor's never going to know whether or not your kid missed school, unless you tell them. And doctors should know whether or not the child they're treating is able to engage in the core activities of childhood, school being one of them, right? So if you have a kiddo who's missing, 3 days or 5 days a month, let's say, either because of asthma or, we have menstrual cramps was one of the examples, or anxiety, that's a conversation to have with the doctor, because at that point, the doctor might say, gosh, do I need to change what I'm doing on the medical side to help manage this better or differently? Do
Mhm.
I need to do something differently, doctor? Or do I need to give the school information with parents' permission about how to better serve this student? Do we
Mhm.
need to make adjustments to the student's plan? Do we need to talk about home and hospital? Do we need to talk about changes to the IEP? Um, but none of those conversations can't happen unless the parent, and again, this is one of those unfair places where we put a burden on parents, um, unless the parent raises it and says,
Mhm.
"Hey, doc, you know," because school attendance, some clinicians are viewing it more and more as an indicator of health and wellness.
Mhm.
Like, how many days are you missing? And that's an indicator of a lot of things. And it can be an indicator of whether or not the treatment plan that the clinician is engaging in is effective. Um, and I think, there's this lack of provider alignment. And I think it's interesting to see sometimes, I've seen this in a couple of cases with young people who have mental health concerns. You know, the school-based clinician, the clinician the child sees outside of school, the medical folks, they do not all have the same information, and they might not all even have the same goals, right? One is managing behavior, one is doing something else. And this is again a place where the parent as case manager is not a good thing, is not a good thing, but because the parent is the rights holder, unless that parent has empowered somebody else, like the actual case manager, to do that case management, the parent is in this terrible position because they're the only one who can free up that information flow. Um, so it's really a very interesting space to operate in. Um, okay. Was there anything you wanted to say particularly about the school-based mental health, the behavioral health, Danielle, before we flip to the next slide?
Yeah, just quickly, I think what gets confusing, and perhaps this is true of all the different various like school-based providers of any kind of medical care, is confusion about who they work for. um, Previously, all of the school nurses were actually employees of Children's National Hospital who was contracted to provide those nursing services. That contract ended, and now the district has been required to replace all of those individuals. And so DC Health is now in charge of that. But even under DC Health, those nurses that DC Health provides are not employees of the school. And I think what I often forget is that because they are working in a school doesn't mean they necessarily know everything that the school knows. Because if they are not kind of directly answering to school leadership, they may not. If you were like, well, I told the assistant principal that my student was missing school because of mental health issues. But then if that person isn't necessarily in the same loops as the school-based clinician, because the school-based mental health clinician actually works for a CDO, a community-based organization that's been contracted by DC's Department of Behavior. See, like the chain of how these connect sometimes gets so distant that we assume that everyone's talking to each other, and they aren't, for one thing. And in some places they can't without, as we talked about before, the explicit permission of the students, like legal guardian. So I highly recommend the school-based behavioral health program. If folks have good, bad, or ugly experiences with that, I welcome those because, as Chioma mentioned before, we have a Strengthening Families Coalition that is specifically working to improve the quality and the consistency of the school-based behavioral health program. So I want feedback of all kinds on that. Thank you.
Perfect. And then, and I'm mindful of the time, so I do kind of want to ramp us up a little bit faster. Other pain points where parents kind of talk particularly about attendance, but also where some of these systems are like really not working out so well, is when there are other factors involved, like families who are experiencing housing insecurity, right? And there's particular protections that protect students who are currently homeless. And please know, homeless in this context has a very liberal definition that is not necessarily what people think of. But students whose health and attendance concerns are impacted and they are homeless, are entitled to additional protections under McKinney-Vento. And then parental and caregiver disability is a very real factor here. You have a right to parent while you have a disability. People with disabilities can and do become parents all the time and are parents. And there are statutory protections for parenting while you're a person with a disability. Those protections look different because they have a different legal sounding. They sound in the ADA and the DC Human Rights Act, and they are, the parent is a different legal entity. So they are different, and sometimes people don't always hear them, and it doesn't hit them the same way. But we can do some work around that. And there are rights that attach there. I also want to flag language access as a huge issue in this space. Not only because of navigating the school part of it, but also, healthcare providers have affirmative obligations to provide language access that is often forgotten about. And that means forms and documents. And then I also just at a very high level, and this is something of a pet peeve of mine. I think Danielle has used the word soapbox a little bit. This is one for mine. Um, I have a huge problem when schools and clinicians disagree about what the other one is doing and then tell the parent to go fix it. So, the school is told, the school says to mom, hey, look, you got to talk to your doctor because this isn't working. And then the doctor says to the mom, Mom, you got to do a better job of this IEP advocacy because this is unacceptable. That drives me bonkers. Okay. Um, and I just want to let you know that, one reason why that happens is because, the school has no right to do anything to make the doctor do anything, and the doctor has no right to make the school do anything. The only person who can access those dispute resolution options is the parent, which is frustrating, right? And it's putting a burden on somebody that is not necessarily equipped in that particular moment to do that. So I always like to be very mindful of that, and I often feel I'm very sensitive to families who feel pulled between their doctor and their teacher, their kid's teacher, because I think that happens a lot. So I do want to remind folks that there are robust dispute resolution options available under IDEA, um, where that is a place where you can have the voice of the clinician you're working with, where your voice can be elevated and issues can be resolved. And schools and parents also have dispute resolution options under Section 504. Um, and then the hypothetical I just mentioned, when there's a disagreement between the medical and education systems about what the other should be doing, it puts parents in a terrible position. And I really, there's things we can do to help resolve that. Part of that is, facilitating that communication between the school and the clinician, and not putting yourself in the position where you're forced to um, kind of carry water for the other government agency who's receiving federal dollars that you're not receiving, to do this work. But I do just kind of want to flag that is a real tension that many, many families feel when they're navigating these two systems. Whew. All right. Last one. Do you guys remember that chart that Colleen had with like all the numbers? Do you remember that? With like all the numbers about like when kids go get annual screening, and who goes to the doctor and all that stuff. And did you see when the kids turned like 18, they stopped going? Yes, you guys remember that chart. It was like an hour and a half ago. This is a big issue. Okay, Chioma's laughing at me. But that chart is so important. And we have two systems that do a really lousy job of preparing kids for handling their own healthcare. Okay, and probably actually three, because I didn't start talking to my kids about how to handle the doctor until I started working at AJE. And that's ridiculous. I should have done better. Um, transfers of rights happened in the education context at 18. AJE's been talking about that forever, but it also happens in the medical context at age 18. And that means that clinicians, schools, and families need to provide and prepare young people for managing their health when they turn 18. People have a lot of preferences here and what they want schools to do and what they want their doctor to do, how comfortable they feel, how much trust there is. But I just want you to realize that chart that Colleen showed, where only like 32% of our kids who are 18 to 22, I just made that number up. I don't remember what it actually was. I just knew it was jarringly low, um, are getting their annual health exams. That's not inconsistent, especially for young men. So please know there's these two systems that are kind of dropping the ball. Um, and families are dropping the ball too. I mean, I definitely was one. I like had my oldest kid. I'm like, I'm sorry, what? I have to do what now? You have to call in your prescriptions because I can't. And I worked at AJE at the time, and I didn't put that together. Um, so that is where I am ending. Danielle, did you want to throw anything else in there with
No,
our
I
8 minutes
think you
left?
got it covered. We guys leave time for you all to ask questions.
Yes, let's get to questions. And I know there's a Zoom poll, so we hope that we don't have to go over. So please, if you have, there are already existing questions, so I'm just going to start from there. Um, And please add some more if you have. This has been really enriching. Thank you so much, Danielle and Maria, for this. And I was looking at the graph that you mentioned, Maria, and it says that for 10 to 14-year-olds, it's 52%, 15 to 18-year-olds, it's 43%, 19 to 20-year-olds is 22%. So, and our kids can be in school till 21. So that's interesting. Um, so Brandon asks, who determines what appropriate means when we say free and appropriate public education?
Oh, he's
Appropriately
baiting
ambitious
us.
public
Brandon's
education.
baiting us because that is an IEP team decision, and Brandon knows that. Um, but yeah, it's an IEP team decision. And the great thing about that is that's a place and a format where the parent can loop in the medical system, right? They can bring the child's clinician to that conversation. Now, that's a lot of work. It's hard. Sometimes you're only bringing the child's clinician to that conversation in the form of a letter. But that, that is an IEP team decision about what is appropriate, what are the appropriate levels of services. But it's also that avenue and that conversation and that consensus decision is a place where we can loop in the health system.
Right. So then the follow-up question that you just answered it, which is that the conversation happens with the parent or the youth in the IEP meeting. That should be the appropriate place to determine what is appropriate, right? Okay. Um, and I would ask if that doesn't happen, what then can you do? But let's not go down that rabbit hole. You can call AJE for that. Um, and so let me see. So we answered the question about PTSD and bullying as a cause of absenteeism. Brandon also noted that absenteeism can be a response to restraint and seclusion. I don't know if you guys want to say anything more about that piece.
Yeah. I think we talked about school as a place of trauma and hurt sometimes, and I think restraint and seclusion is a great example of that. I see Danielle nodding, so I'm gonna.
No, I was just agreeing that there are all sorts of things that schools do that don't make a child feel welcome, right? And I think that some of our conversations about absenteeism rely a lot on like, why didn't they go? Like, what did you parent not do? And that resulted in your child not coming to school. And I really want to encourage school-based folks to, and I think Maria's talked, doctors are starting to do this, that seeing absenteeism as a symptom of something rather than the problem in and of itself. I'll try to stay off my soapbox there.
Thank you. And Emil, I think you have a question. This will be the last question, and then we'll transition.
No, this is actually a comment I wanted to add on top of not only school being a place of trauma for children, but a lot of times, especially these services will forget that parents will also want children in school and have trauma from school itself. And that also has an effect with how the parent of that child will address the situation in school because there's underlying trauma that they experienced in school, you know, we have to kind of look at it from a holistic lens if we're going to.
Yeah, and that parent trauma is not just past. They can bar a parent from a school, and I believe that can be traumatic as well. But I don't know, Maria, Danielle, let the experts speak to that.
Uh, trauma. There's a lot of trauma at the school for everybody involved. I don't. I'm not going to even pretend. I mean, I've had law enforcement at IEP meetings because they are worried about a parent's behavior. I can't imagine a more clear expression of schools as agents of the state than that. Um, and I do think it's interesting. I mean, I used to teach. I love schools. I care about schools. I think schools can be a beautiful, liberating experience. But I also think we forget that these are agents of the government, and
Mm.
that's a different ball of wax. That's just not. That's just that's the big heavy hand of the law. It just has a lady in like a kindergarten outfit looking thing in a,
Right. And
federally
that's going
jumper.
to impact different people differently, right? I mean, that fact alone, while true in all places, is going to hit differently for communities that do or don't have sort of trauma connected to agents of the government. whether that's, connected to policing, or the criminal legal system. It could be connected to the child welfare system. And I don't think, I mean, at least I was a teacher many, many moons ago, and I didn't consider myself an agent of the government in that way. And I never, as a kid in, a tiny suburb in nowhere, Kentucky, didn't see my teachers as agents of the government. But they were, and that kind of reflects my experience with both agents of the government and school. And I think it's hard for schools to hear that they may be serving a community that is not the community they may have experienced themselves as a child, and trying to frame that conversation in a way that isn't accusatory, but the school has to realize like the role that they play in it, whether that was their intent or not.
Thank you for that. Actually, Eli, there's one more, and then please,
I like
everyone,
it.
stick around for the poll, which is Yvette asks in the chat or makes a comment
Hey
that says,
everyone, sorry, my screen is freezing, but we just have two more polls. Can we make sure we just prioritize those polls so we can end on time?
yes, but I do want to honor Yvette's commentary here, and then we will punt to that, which is that for the nursing techs, do they have systems in place which hire people with expertise of how to administer whatever the medication or EpiPen for children with disabilities like her daughter, eye drops at the doctor, she flips out. So she has a sensory sensitivity to these eye drops, and is there a requirement of the schools to have somebody with that level of training? Mm.
So schools have to train their staff to serve the students they have. So there isn't like a blanket obligation that they have to be able to do X, with some exceptions. But what they do have to do is train the staff to serve the students that are before them, which might mean, learning how to do a G tube or learning how to help monitor, you know, a, a diabetic monitor smartphone doodah thing. Or it might require, how to train the health tech to serve to make sure this child is able to get the services they need at the school. Um, so the answer to your question is super fact specific, right? Because it depends on each school, but the obligation is to serve the students they have, to provide that student with whatever it is that they need that provides them access to the program. Does that kind of make sense? It's a very lawyer answer, and I'm sorry, but it's the one I got.
Yeah. I mean, I think it's just that like they don't necessarily have to hire someone with that existing experience, but they do have an obligation to make sure that that person learns how to meet the needs of the kids in front of them. So even if they don't have it, they are obligated to learn it.
Yeah. And the district does have a
Okay.
huge shortage right now of AOM, administration of medication trained staff. That is a huge problem. We're working on it. Everybody's working on it, but it is an issue just overall.
Okay, I just want to note that it is currently 8:01, and we do want to run two Zoom polls. So please stick around. Unfortunately, we will have to release and thank so much our Spanish interpreters. And if you're free to exit, and we hope that that there's a way we can create more inclusivity in terms of these two poll questions, and we can follow up with any family member that may want to address these answers in Spanish. But Danny, I'm going to punt it to you to run the polls and close us out. Thank you so much, Maria, Danielle, and Colleen, for your time tonight. Back to you, Danny.
Thank you. Okay, hopefully this works. I know my screen's been lagging so much, so be patient with me, please. All right. So question 3, when a student has a health-related absence, what do you believe is the school's primary responsibility? And if you have something else besides this, you can type it in the chat. Okay, we have 3 responses, trying to get to a few more.
Danny, do you see Jocelyn's question about she must be on her phone and it faded? Is there a link for this question?
No, just because it's a Zoom
Yep.
poll, but no worries
Don't worry
about
about
that.
it, Jocelyn.
Yeah. Okay, so I'll just go ahead and end the poll and share the results. We had the most votes for help the students stay on track academically. And then the one that came close to that was ensure attendance is documented properly. So some of the things that we were already talking about. And then let's go to the fourth question. After tonight, what action are you most likely to take? We have take time to process what I learned today, learn more about my child's rights and available supports, review my child's IEP, request an evaluation or additional services, speak with healthcare providers and supports about supports and referrals, connect with school staff, connect with advocacy organizations or resources. I'm not sure yet, or if you have another response, you can type that in the chat box. I hope reading them helped out loud. So if you can't access the Zoom poll, you can drop it in the chat. All right, we have 6 responses. I'll just give you a couple more minutes to wrap up those answers. Okay. So for here, we had just take time to process, and I love to see that. We have the live binder has great resources, and you can always go and check out those links, even the live binder from last year that is still accessible and open to you all. All right. Well, thank you all so much. I know I'll pass it briefly to Maria since she just wanted to give some advice about memorializing. And and then after that, just giving a reminder that after what Maria shares, there will be a deeper conversation about everything that she mentions in the workshop that we have next Thursday at 6.
Hey, thank you, Danielle. Danny, I forgot about that part. We have a really great resource on the website. If you just go into the RAJE website and type in CYA in the search, and I know it's kind of cheesy, in the search feature, we have a great research called Cover Your Amazing Kid, CYAK. But it's a great bundle of templates about how to communicate with schools, about your concerns, how to access records, but also how to memorialize conversations, including conversations about school attendance. One of the things that we've uploaded that I've asked Danny to upload to the live binder is also our attendance handout, which again, very helpful. It breaks down all of the rules about attendance in DC, including the deadlines for submitting documentation. When can you submit documentation just as a parent? When do you need outside documentation? And how to memorialize that. I think that's something that lawyers we get that beat into us in law school where, if you don't write it down, it didn't happen, but they don't tell you about that when you pick up your baby at the hospital to bring them home. So it's helpful and useful to know how to do that. We give you some templates to help you communicate with the school, and make sure you're giving the school the information they need to process your child's absences correctly. I do want to shout out some great resources that Chioma shared and created around home and hospital instruction. We have a blog post about that too. And CLC deserves, honestly, a lot of love from the whole community for the work they did around pushing for the home and hospital legislation to be passed in the first place, and then for the regulations to be implemented, and then finally for the program to be up and running at all the LEAs. So I do want to really give them praise for that. It was kind of there's still work to be done, but it was a big mess before, and now it's a more manageable mess. But we've made a lot of good progress there. So I do want to thank that. I also want to be respectful of people's time and stop talking.
Thank you all. I just wanted to appreciate this conversation and being included.
Okay. Well, thank you all again. We hope you have a good night, and you can check out the Health Policy Camp live binder where you can see the future events. We have one tomorrow at 2, and then another one on Monday, which actually will be a theater production. So if you would like to join us, please do be in person. All right. Have a good one, everyone.
All right.
A
Thank you.
theater production by our Youth Advisory Board members. Oh,
That is
so
true. Little shout.
Thank you.
Exciting.
Thank
Thank
you,
you,
Colleen.
Colleen.
Thank
Appreciate y'all. Have a good night.
Thank
thank
you.
you. You too.
All right. Good night.
And good night.
Good night.